Welcome to PharmaconHealth, where complex pharmacology becomes clear, clinically relevant knowledge. Today, we're exploring a fundamental process, drug metabolism, also called biotransformation. You'll discover how your body chemically transforms medications, why these changes are crucial for drug effectiveness and safety, the clinical implications every healthcare professional needs to know from activation to elimination. Let's break down this vital pharmacological process. What is metabolism? Metabolism, or biotransformation, refers to enzymatic processes that chemically modify drug molecules, typically to increase their water solubility, aiding excretion. This process can detoxify harmful compounds, convert inactive prodrugs into active forms, or deactivate drugs to stop their action. Sites of drug metabolism. The liver is the main site of drug metabolism because it has a high concentration of enzymes like cytochrome P450, which chemically modify drugs to help eliminate them. For example, drugs like warfarin and diazepam are primarily metabolized in the liver. However, other organs also contribute. The intestines metabolize some oral drugs before they even reach the bloodstream, like verapamil, reducing its bioavailability. This is known as the first pass effect. The lungs can metabolize inhaled drugs such as theophylline and also help break down volatile anesthetics. The kidneys contribute by metabolizing some drugs before excretion, as seen with atenolol. The skin metabolizes certain topical medications, like corticosteroids, locally to limit systemic effects. Even plasma contains enzymes that can alter drugs in the bloodstream, such as procaine being hydrolyzed by plasma esterases. Together, these sites ensure drugs are chemically transformed efficiently, protecting the body and preparing drugs for elimination. Phases of metabolism. Now, let's break down drug metabolism into two major phases, Phase 1 and Phase 2, each with distinct functions. Phase 1 drug metabolism, functionalization reactions. Phase 1 reactions are the body's first step in preparing drugs for elimination. These reactions introduce or expose functional groups such as hydroxyl, amino, or carboxyl groups on the drug molecule. This is done to increase the molecule's chemical reactivity and water solubility, making it easier to modify further or excrete. The major types of phase I reactions are oxidation, reduction, and hydrolysis. Among these, oxidation is the most common and is primarily catalyzed by a superfamily of enzymes known as cytochrome P450, especially CYP3A4 and CYP6. This enzymatic modification often converts lipophilic, or fat-loving, drug molecules into more polar and hydrophilic forms that the kidneys can eliminate more efficiently. In some cases, Phase 1 metabolism also activates prodrugs. For example, codeine is converted into morphine through CYP6, allowing it to exert its pain-relieving effect. Overall, Phase 1 metabolism plays a crucial role in reducing drug persistence in the body and preparing drugs for Phase 2 conjugation. Phase 2 drug metabolism, conjugation reactions. Phase 2 metabolism is all about conjugation, attaching polar groups to drugs or their Phase 1 metabolites. This process significantly increases their water solubility, making them easier to eliminate through the kidneys or bile. Common conjugates include glucuronic acid glucuronidation, which is the most frequent conjugation reaction. For example, morphine is metabolized into morphine 6-glucuronide, an active form that prolongs pain relief. Sulfate groups, sulfation, are added to drugs like acetaminophen, enhancing elimination and reducing toxicity. Acetate groups, acetylation, modify drugs such as isoniazid, affecting their activity and clearance. Conjugation often converts drugs into inactive forms, but sometimes active metabolites result, impacting duration and intensity of drug effects. This step is crucial for detoxifying and preparing compounds for safe excretion. Pharmacogenetics and enzyme variability. Genetic differences in drug metabolizing enzymes cause significant variability in drug response across different populations. For example, CYP6 polymorphisms vary by ethnicity. About 5 to 10% of Caucasians are poor metabolizers, leading to slower conversion of codeine into morphine, which reduces pain relief. Meanwhile, Some North African and Middle Eastern populations have higher rates of ultra-rapid metabolizers, increasing the risk of toxic effects from standard doses of codeine. CYP to C9 variants are more common in Caucasians and affect metabolism of warfarin, requiring careful dose adjustments to avoid bleeding complications. CYP to C19 poor metabolizer variants are frequent in East Asians, which can reduce the activation of clopidogrel, increasing the risk of heart attacks or strokes. Additionally, CYP3A4 is the most abundant cytochrome P450 enzyme, responsible for metabolizing over half of all drugs, including statins and calcium channel blockers. Although CYP3A4 has less genetic variability, it is highly influenced by drug interactions that can alter its activity. Understanding these genetic differences helps clinicians personalize drug choices and dosing, improving safety and treatment effectiveness. Enzyme induction and inhibition. Some drugs can induce metabolic enzymes, increasing enzyme production and speeding up the metabolism of other drugs. This often lowers drug levels in the blood, potentially reducing effectiveness. For example, rifampin induces CYP enzymes, which can lower levels of drugs like warfarin or oral contraceptives, risking treatment failure or unintended pregnancy. Conversely, some drugs inhibit metabolic enzymes, blocking their activity and slowing drug metabolism. This raises drug levels and can lead to toxicity. For instance, ketoconazole inhibits CYP3A4, increasing levels of drugs like simvastatin, which can cause muscle damage. These enzyme interactions are especially important in patients on multiple medications known as polypharmacy because they can drastically change drug effectiveness and CYPs. Clinicians must carefully monitor and adjust doses to avoid therapeutic failure or adverse effects. Common enzyme inducers and inhibitors. Drug examples. Let's look at some common drug examples that act as enzyme inducers or inhibitors. Enzyme inducers like rifampin, phenytoin, carbamazepine, St. John's wort, and phenobarbital increase the activity of metabolic enzymes. This often reduces the blood levels and effectiveness of other drugs. In contrast, enzyme inhibitors such as ketoconazole, erythromycin, cimetidine, grapefruit juice, and ritonavir slow down metabolism. This raises drug levels and increases the risk of toxicity. Recognizing these interactions is critical in preventing adverse effects and therapeutic failure, especially in patients on multiple medications. Prodrugs and clinical strategy. Prodrugs are inactive compounds that require metabolic conversion to become pharmacologically active. This strategy helps improve drug absorption, stability, and allows targeted activation within the body. For example, codeine is metabolized by CYP to D6 into active morphine, providing pain relief. Similarly, enalapril is converted in the liver to enalaprelate, its active form that lowers blood pressure. Prodrugs can also reduce side effects by limiting activity until they reach specific tissues. Understanding prodrug metabolism is essential for optimizing drug design, choosing the right dose, and predicting patient response. Clinical relevance of metabolism. Drug metabolism plays a crucial role in clinical practice. In patients with liver disease, the metabolic capacity is reduced, leading to slower drug clearance and potential accumulation, which increases toxicity risk. For instance, drugs like phenytoin or warfarin require careful dose adjustment in such cases. Neonates have immature liver enzymes, resulting in slower metabolism and prolonged drug action. Similarly, elderly patients often show reduced enzyme activity, which can alter drug effects and increase sensitivity to medications. For drugs with a narrow therapeutic index where the difference between an effective and toxic dose is small, such as phenytoin and warfarin, therapeutic drug monitoring, or TDM, is essential to maintain safe and effective levels. Now that we've explored how the body transforms drugs, next we'll look at how these compounds are eliminated through the process of excretion. Want to learn pharmacology without the overwhelm? Join the PharmaconHealth community where complex topics become crystal clear. Subscribe for more focused content, clinical cases, and animated breakdowns that make pharmacology make sense.